Hey everyone, welcome back to another Facebook Live here at NewSouth NeuroSpine. My name is Lanier Clark and I'm the marketing manager. And we are in our surgery division again today, and we have neurosurgeon Dr. John D. Davis with us. He just came out of a case and he is going to be talking about the importance of second opinions. It's important to be your own patient advocate, especially when it comes to surgery. So if you have any questions about that, feel free to comment and watch with us. If you do leave a comment, I will be choosing someone to win a gift card. So without further ado, let's get started, and here is Dr. John Davis.
All right, thanks so much, Lanier. I appreciate it. Thanks for the enthusiastic introduction. All right, so we're going to talk about second opinions today, and I thought we'd do it in sort of a question and answer sort of format, and apologize for the surgical hat here, but it'd probably be worse if I took it off. So why don't you ask me, those first two questions that I saw, they're almost one and the same. So why don't you ask both of those questions? I'll repeat them.
Okay.
And
so, Dr. Davis, why is it important to get a second opinion, and should everyone get a second opinion when surgery is recommended?
Yeah, so those are similar questions, and they're very good questions. A second opinion is the importance of a second opinion. Frankly, depends on the quality of the opinion that you got in the first place. So. And that's tricky because the average patient, they're there because we've worked and trained all these years to be able to provide our opinions and our advice about what they need for a problem that they've come to us for. If they knew and understood all this stuff, they wouldn't have to come see us in the first place. So it is tricky to know when you need a second opinion. My advice to patients, in fact, my advice to my own patients, if they have any questions or feel uncertain, is to get a second opinion. And I've told patients many times that if you're seeing a physician and you mention the possibility of getting a second opinion and then maybe giving it some more thought before you move forward with surgery, and that physician gets upset with you because you've chosen to go and see someone else for a second opinion, to me that is quite a red flag. And the way I put it to my patients is you should pick your stuff up and get out of there. Yeah. Because if somebody's so offended by the fact that you might want another opinion, it's probably not somebody you want to stay with. But it can be extremely important. And one of the ways to make that determination is if you've not had symptoms very long. So if you've had symptoms for a very brief period of time, maybe a few days and maybe 2, 3, 4 weeks, and you're seeing a surgeon and the recommendation is being made that you go to the operating room. Now, it may be the exact correct recommendation, even that shortly after symptoms have started, but in most cases, that's earlier than we would normally, in my practice here, in the practice of my partners, be recommending an operation. If you have some bone spur or herniated disc that's dug into your spinal cord, and you have symptoms from that, and maybe even a bruise or signal change on your spinal cord, it doesn't matter if your symptoms started a week ago or 6 months ago. Surgery is probably the answer for that. If you experience the onset of pain in your neck that shoots through your shoulder and goes down your arm, and that started, 1, 2, 3, 4 weeks ago, oftentimes there are conservative measures that will provide significant relief, significant improvement, that will allow you to avoid surgery. Now, the problem can be sometimes that is pretty painful, but I've found if you can reassure a patient and make sure that they understand that you're there for them, and if things become unbearable, there's not going to be some extensive wait, and I called your office 5 times, and I need to come back in and have something done, but that you're going to be there for them in a very timely way, but you can offer other non-surgical options. People are able to, even if they have to grit their teeth a little bit, hold off on having surgery and attempt some non-surgical conservative treatments, the most important of which can actually be just the passage of time and avoid having to have an operation. So every case is a little different, but I do find that there are a lot of times when patients can avoid surgery, and if they take the time to go get a second opinion, if surgery has been recommended.
Do you see a lot of second opinions?
I see a good number of second opinions. Yeah, I really do. I see a fair number of workers' compensation second opinions, and these are people who've been hurt or injured in the workplace. You know, those usually come to me when the people in the workers' compensation system, like a caseworker or adjuster, become suspicious that maybe something that's been recommended needs a second look. And then that's what will generate those. But I also see second opinions here in the office for patients who've been seen somewhere else and had an operation recommended. So yeah, I do actually see a significant number of second opinions in my practice.
Talk about a time when you had a second opinion and maybe the other doctor recommended surgery and you didn't. What was the outcome, and how did the patient feel?
Sure. Well, you know, that can get a little bit different if you're in the workers' compensation arena with patients, you know, who've been hurt at work. You know, sometimes there can be a suspicion if a surgery's been recommended and they're hurting, they're having trouble. Surgery's been recommended. If you recommend something different, you recommend against surgery or to try something different, that can, for some of those folks, raise a suspicion. They're just thinking, oh, you know, are you really looking out for my best interest? Because it gets complicated because of the third party, you know, system, and sometimes there's litigation involved. But in the non-workers' comp world, I've seen a lot of people who may have had a very reasonable recommendation in the broad sense. And let's just say somebody woke up one morning and felt like what they thought was a crick in their neck, and they could almost put their hand on it. It's like right back here, and it really hurts, but boy, by the end of the workday, they come home, and this pain is not just in their neck anymore, but it is now, over the course of a few hours to a few days, begun to spread down their arm, into their shoulder blade, down their arm, with numbness and tingling, sometimes a sense of weakness in that arm. And they have gotten an MRI scan, and the MRI scan shows that they have a herniated disc pinching a nerve in their neck. So is it legitimate to do surgery on patients who have herniated or ruptured discs in their neck? Well, absolutely. Thankfully, that's probably the most common operation that I do in my practice, is dealing with ruptured discs in people's necks. However, just because you have a ruptured disc, many people don't realize that doesn't mean that you should necessarily be destined for surgery, or that you have no other choice other than surgery. And I think there's an inclination, and I understand this way of thinking because I was an engineer in college and I went into surgery because I like to fix stuff. But there's a inclination in a lot of patients who find out that they do have a herniated or a ruptured disc, that, you know, they want it fixed. You know, why are we messing around with this? Why are we doing traction? Why are we doing therapy? Why are we doing steroids? Why do we do epidural steroids? If I've got a broken part in me, why don't we just fix it? And, you know, these are situations where I have the opportunity to educate patients about something that they really would have no reason or way to know about otherwise. And, you know, I see the lights kind of come on in patients' eyes sometimes when I say, hey, most herniated or ruptured discs shrink down and essentially go away on their own in most cases. Okay? Now, That's too bad for me. I could retire a lot earlier, right, if that weren't the case. But the truth is, disc herniations can shrink down and go away on their own. And in fact, they will do so in a majority of cases. And most patients don't realize that. They think once you have a herniated or ruptured or extruded or protruded or slipped, and these things essentially mean the same thing. Rupture sounds worse, right? So you say, oh, you've got a ruptured disc. Well, there's an immediate assumption, I've got to have surgery. Mm-hmm. Sometimes that's true. Oftentimes that's not true. So I will see a patient sometimes, they've been seen, they do have a legitimate structural problem, they do have a herniated disc, they do have pain, maybe they even have some weakness that they've noticed or that a doctor that they've seen has been able to determine when he examines them, and they've had surgery recommended. It's not that that's a foolish way to proceed, mm-hmm. but I've seen many patients over the years when or who have had a brief period of symptoms. And when I explain to them that in most cases a disc herniation will shrink down on its own if we can give it time, they're perfectly willing to give it time. And I think that, the knowledge that, hey, look, if this suddenly gets worse, you can always go have surgery to fix it. But in the majority of cases, it's going to gradually get better with time. And if we can bathe that nerve in steroids, either steroids you take by mouth or actually, literally put the steroid with an epidural steroid injection right where the problem is, those nerves will calm down and patients will enjoy some benefits, some pain relief while we're just basically given this time. I mean, the biggest healer of ruptured or herniated discs is not epidural steroids or traction or physical therapy. It's actually the passage of time. Mm-hmm. Yes. But if you're hurting, passage of time ain't a lot of fun. And if you don't have that reassurance from somebody you trust that, hey, in a majority of cases, this is going to fade and go away on its own, mm-hmm. then it doesn't feel very good at all to give it more time. Your inclination is, oh, no, let's go have the surgery to fix it.
Yeah. So Monica has a good question. She says, if you have a second opinion done, do you have to continue to be treated by the second physician? And if both physicians agree on the treatment plan, can the patient have the treatment with either of the doctors?
Yeah, I mean, ultimately, my rule is always that it's the patient's choice, really. Now, I've had patients who've had surgery just a few weeks ago, and they're still having a hard time, and they want to come see me for a second opinion then. Well, that's not the appropriate time really for a second opinion, at all. There's not a question about whether you need surgery or not. Surgery's already been done. And honestly, it's best that the surgeon who's done the surgery be the one who you stay with and they follow you through this whole recovery process. But no, I mean, at the end of the day, it's the patient's choice. And I think that it's never the right thing to pressure a patient to stay with you, mm-hmm. or not treat with someone else. If I've seen a patient and they decide to go see someone else for an evaluation or for a second opinion, and they're more comfortable with that doctor, that's who they should stay with. Right. And it really should be the patient's choice. There's no obligation to stay with that doctor. If a patient comes and sees me, I do a second opinion. My general advice, as long as my opinion concurs mm-hmm. with the other treating physician's opinion, is go back and see the doctor who you saw in the first place. He and I are exactly on the same page. As long as I can look him in the eye, and say so, I'll tell him you're in really good hands. This doc's going to take good care of you, and his thoughts about what ought to be done or not done are exactly in line with mine.
Does insurance cover a second opinion?
Yeah, that's a good question.
Yeah.
The insurance absolutely does. So it's just seen as a new patient visit, okay. is what it is. So it would be the same as when you came to see the first physician. whatever charge is generated by that. If you decide to get a second opinion, it's essentially the same code that we use to bill with. So yeah, insurance is fine with that.
Okay, another question. I know sometimes with second opinions, people come in and you might order a new test.
Mm-hmm.
And sometimes that can be confusing to patients. You know, why are you ordering this? I already had
Right.
an MRI. Talk about why you would order another test.
Right.
And then also the difference, like X-ray, MRI, and
Right.
myelogram.
Right. So, I mean, it would be extremely rare for someone to have a surgery recommended based on just plain X-rays. So the vast majority of people will have had an MRI scan. So situations in which I see a patient who may have seen someone else and had surgery recommended based on an MRI scan, but I'm recommending additional testing, is when I study the films and it's not entirely clear to me that the things that I'm seeing on that film are the cause of what the patient is in the office having problems with. Another situation would be if someone has an MRI scan, but that MRI scan was done several months ago. I'm personally not comfortable operating on someone based on findings that were on an MRI scan several months ago for the same reasons that I alluded to before, which is disc herniations do what? They shrink down and go away on their own most of the time. Mm-hmm. So if someone's had has a disc herniation, surgery's been recommended, but that MRI scan is 5-6 months old. If I'm gonna be the one treating or operating on them, I'm gonna insist on an updated MRI scan to make sure that the disc herniation hasn't shrunk down. Or I've seen cases before where that disc herniation shrunk down, but they actually had a herniated disc at the next level. And if I had not ordered updated imaging, then I would have operated where the initial herniated disc was, but where it no longer was. And then when they didn't do well, we would have gotten additional imaging, another MRI scan that would have shown, there's a new disc herniation that you would have seen if you'd ordered it. So there's no precise line in the sand. Mine is generally around the 3-month mark. If your films are over 3 months old, usually, but not always, usually I'm going to order updated imaging. Another situation arises where, again, it's just not entirely clear to me that what's causing a patient's symptoms on their MRI scan. I mean, maybe they do have a little disc bulge. Maybe it looks a little snug around a nerve, but the findings are subtle enough that I'm just not convinced that that is what's causing this patient's problem. Then I may order a myelogram, which is a slightly more precise way, a little more invasive, because they do have to do basically almost a spinal tap, and instead of taking fluid out, they put dye in, right? They do it when it's done by radiologists. Generally, it's under live X-ray, so it's not terribly painful. It's a little uncomfortable. It's not bad because doing it under live X-ray, they're able to get the needle right in immediately because they can see under live X-ray exactly where they need to be. But that will sometimes clarify whether a place that it's sort of, where it's just unclear. I've gotten myelograms before where I was like, gosh, the MRI scan's not very convincing. And then you get the myelogram, you're like, wow, so that nerve is really pinched.
Lights up the nerve and everything.
Yeah, so there's dye. What happens is you put dye in the spinal fluid sac, and then at a level that's normal, you'll see the dye filling out those nerves as they're starting to exit the spine. If there's a nerve pinched, then there won't be any dye there. It'll be a dark spot there. And you call that a defect. There'll be a defect in the nerve root. And so we do the myelogram, and then we get the patient in a CAT scanner and do a CAT scanning through there. And that's and if it shows, it may show that a nerve's pinched, or you might have been suspicious that a nerve was pinched. You get the myelogram, and you're like, man, that nerve's got all the room in the world. So whatever's causing this problem, that nerve is not the problem. If we unpinch a nerve that's not pinched in the first place, the patient's not going to do well, right? So sometimes we have to get EMG nerve conduction studies. So that's an electrical study. It's sort of a, it's like an EKG for your, it measures the electrical signals in your heart. EMG, nerve conduction studies, measure electrical signals in your nerves. So nerve conduction velocities, which measures how fast the signal transmits in a nerve, that's one of the ways that we check for, say, carpal tunnel syndrome. We also, with the EMG study, can see what we call a radiculopathy, which means a nerve that's not functioning very, very well. But, there are times when people will have numbness or weakness in a leg or in an arm, and you look at the MRI scan of the neck, and it's just not that impressive. You're like, gosh, yeah, it's a little snug around there, but I'm actually suspicious. If you sit and spend time with the patient and listen to them and examine them carefully, you might become suspicious that maybe this is a problem with maybe this is carpal tunnel syndrome, or maybe it's the funny bone nerve pinched at the elbow. Both very, very common problems that can be mistaken for a nerve pinched in the neck.
Huh. Interesting. So let's talk about when, say you do get a second opinion and it's non-surgical and the patient wants to treat here as they live you. What are some non-surgical options when surgery isn't recommended?
Sure. Well, that's a super important point, because it's critical for patients to understand. In fact, we spend an enormous amount of time over here in the surgery division, my surgical partners and I, counseling patients and talking with patients about the non-surgical side of things. Even though we're surgeons, the vast majority of spine problems actually are non-surgical. It's only a fairly small minority of problems that people develop in their spine that truly require surgery. So the reason we built this 50,000 square foot building and have 12 and about to be 13 physicians in this building, and nearly half are not surgeons, is because we think that cutting edge or the best possible non-surgical care should be provided by non-surgical specialists. So that's really two separate groups of people here at NewSouth NeuroSpine. One group are the physical medicine physicians. This is the physical medicine division of NewSouth NeuroSpine. And when somebody comes in and they have a lot of back pain, maybe they have some arthritic degenerative changes in their back, or say they have a lot of neck pain, enough that they finally say, and I'm finally going to see somebody about that. But I see them, and they have multiple level degenerative changes, and it's not a difficult opinion to offer that, hey, this is not a surgical problem. You don't need an operation for this. Well, that, back in the old days, that's kind of, you'd go see your neurosurgeon, and they would say, hey, I looked at your study, looked at your MRI scan. You don't need surgery on your neck, so it's wonderful news, and pat them on the back, and then go out the door, and then, at some point that light bulb comes on. Okay, great, I don't need surgery, but I didn't necessarily come to see you for surgery. I came to you because my neck hurts. What's your plan for that, doc? And by that time, they're halfway to their car. Well, we've got the answer for that now, and we send folks to see our physical medicine doctors. We have 3 physical medicine physicians. I have to explain to patients that these are not physical therapists, because a lot of patients, their primary care doctor, or maybe on their own, they've gone and seen a physical therapist and had physical therapy already. Mm-hmm. And so those people come and say, I already tried physical therapy, I'm not better, so why are you sending me back to physical therapy? And I have to explain that you may need additional physical therapy, but I'm not sending you straight to physical therapy. I'm having you see a physical medicine physician. So the person you're going to see went to medical school just like I did a residency just like I did. They didn't do a residency in surgery. They did a residency in the rehabilitation, largely of spinal problems, the most common spinal problems. And they do a different exam than I do. Mine, I'm checking the neurologic function and reflexes and strength and this is a very musculoskeletal geared, examination in which they manipulate a patient's neck in different directions and figure out, based on a thorough hands-on exam, where's your pain coming from, right? Because somebody comes in, they say, yeah, my neck's killing me. That can be from a lot of things. That can be discogenic neck pain, which is pain that's probably coming from the disc space itself. It can be facet-mediated pain, which is in the back, the joints in the back of your neck. It can be myofascial pain, which is really a muscle-generated pain. And the way you treat those different kinds of problems that will cause neck pain is very different in physical therapy. And so if a patient is getting the standard physical therapy for neck pain, evaluate and treat prescription, and going to physical therapy with it, it may be that the physical therapist, of the countless modalities that they have in physical therapy to treat somebody with neck pain, you may get the right things done, you may not. And so we have 3 physician specialists here who will examine patients and figure out specifically what each individual patient needs in physical therapy to maximize the likelihood that it's going to be successful. The other non-surgical division, we have 2 interventional pain management doctors. These are the guys who do the injections, right? So they're epidural steroid injections, that's most common, but they also do facet joint injections and other kinds of injections as well. And for instance, if someone has a herniated disc in their neck and they have pain and a nerve pinched and pain where that nerve normally goes, unless they have what I consider to be a really risky neurological deficit, like they can't pick their arm up or their hand doesn't work and is just like that, unless it's like that, or unless the spinal cord's pinched, in most of those cases I'm going to try an epidural steroid injection. And the reason is because, again, unfortunately for patients and unfortunately for neck surgeons, it works most of the time. Or in a significant percentage of the time, patients will enjoy significant relief. And with patients, their symptoms and weakness will dissipate. It'll go away without ever having to have an operation in the first place. So that is a common thing. I'll see patients who may have had surgery recommended, and again, it may have been based on a very legitimate structural problem, but I may recommend something non-surgical. It doesn't mean that if they fail that they don't need surgery. It means there's an opportunity to intervene in a way that is less invasive than an actual operation. And if we can get you, I tell patients all the time in my office, if you ask me to choose between getting better, getting well with surgery, or getting well and not having to have surgery, I'll take getting well without surgery every time. So that's not an uncommon thing for us to direct somebody to one of our physical medicine doctors or to one of our interventional pain management doctors to try some non-surgical treatments before surgery. I tell patients all the time, until you've had surgery, you can always choose to have surgery. Again, if you have a legitimate surgical problem, once you've had surgery, you can't take it back. So it's important to be cautious and thoughtful on the front end.
Who are our non-surgical physicians here?
Yeah, so we have 3 physical medicine physicians, PMMR, Physical Medicine Medical Rehabilitation is what that stands for. And those folks are Rahul Vora, Dave Collop, and Michael Winkleman. And then our 2 interventional pain management doctors are Jeff Summers and Dr. Jeff Lassiter.
Ken Treese wants to know, what if a patient is allergic to the dye that they use for a myelogram? Is that?
It's a good question. Yeah, I would have. I didn't know the answer to this question until I came into practice. Even though we did myelograms, obviously where I had trained, it just had never come up. I've never even patients. So if patient has had a myelogram before and they had a reaction to the dye on myelogram, then I would say don't get another myelogram. I have a lot of patients who are iodine allergic. It's not that uncommon, right? I'm allergic to shellfish, which is really because of the iodine, or somebody otherwise knows I'm allergic to iodine. believe it or not, when you put the dye in the spinal fluid sac, it's not an issue. I've never seen a single case of someone having a reaction of any consequence at all who was very much clearly iodine allergic. They can't get the IV contrast, right? So they've got a kidney stone, they need to get an IVP, but they can't get the IV contrast because they'll go into shock. And there are plenty of people out there who are that allergic to iodine. When you put it in the spinal fluid sac, I've never seen a single case of anybody having an issue with it. It's a really good question, and I don't have an explanation for why, when it's in that space, it doesn't produce the usual consequences of an allergic reaction, but it doesn't.
Well, let's talk about what's been going on lately. 2 months ago, we did a Facebook Live with you, and it was right when COVID started.
Right.
Talk about the difference between now and then with NewSouth NeuroSpine.
Yeah, so we're not back to normal yet, but I think we're really pretty comfortably in what I would call a new normal here. I haven't done a telemedicine visit in some time now. I'd be very willing to do that. It's not a problem if somebody wants to do that. I think people understand that, if I'm going to be able to properly examine them, I mean, they have to be in the room with me. I can't test their strength without testing their strength. I can ask them what they experience by telemedicine, but I can't check it myself. And I can't put them through certain maneuvers. So most folks are coming in, even though, it's an option to have a telemedicine visit. People want to come in because they want to know what's going on, and they know that if you can do a full proper exam, that you're more likely to be able to give them the answers that they need. So we're back up to full capacity in that sense. We're almost back to full volume with patients. We're just taking a lot of precautions. And now it's really become such a part of our normal, we don't even think about it, I mean,
you're taking mask wear.
Right. I mean, I mean, you don't get in the building if, we ask you a series of questions to make sure that you've not had an immediate exposure to COVID or that you have any symptoms that might be COVID-related symptoms. And we also then we'll check your temperature, and then we ask everybody to wear a mask in here. Not that wearing a mask eliminates the risk of transmission, but we do believe at this point, as we continue to learn almost daily and certainly weekly more and more about how this virus operates, we do believe at this point that it does mitigate or reduce to some degree the risk of your transmitting the virus, if you happen to have it, don't know it, to somebody else. We're doing the same thing. I haven't walked in a patient room without a mask on I don't know, since this whole thing started. And I wear an N95 mask because the other masks make my glasses fog all up, right? When I'm in the operating room, I tape across there to keep my glasses from fogging up. But then I can't pull my mask off without pulling the tape off, which is fine while you're in surgery. But when I'm walking around the office or sitting in my office, I want my mask to come off. So I'm using an N95 mask, which again, offers a pretty reliable protection for the patient if I happen to have it and don't know it, or asymptomatic, and then also for me. But we're wiping down the rooms now. It's not. It's second nature, right? I mean, our nurses are wiping down the rooms completely between patients in ways that we never did before. I mean, we had a routine before, and things were always very clean. But now it's really an extreme process between every patient in a room. But by being cautious about who we do and don't let in the building in the first place, that includes employees and patients alike, taking these extra precautions with the wipe downs and then everybody wearing masks, we think we've really dramatically reduced the risk to a patient or to us of contracting the virus by coming for a doctor's visit.
Okay, one last question. I want you to talk about the importance of a patient being their own advocate for themselves, whether it's a second opinion or considering surgery. What do you suggest that people that might not know about NewSouth NeuroSpine, how do they do their research? How do they get an appointment?
Sure. Well, there are a lot of ways. First of all, I mean, you can do your research. If you're talking about my partners and me, you can go online and you can read about all of us. You can look at our resumes or CVs. You can see what our background is. There's some videos probably of us still talking about just our philosophy about how we view the care of patients with spine problems. So you can get to know a whole lot about us just by going to our website. I mean, you get to know a lot about us individually and the practice in general as well. And I encourage people to do that. I mean, the time was, you might have your primary care doctor might be with this system, right? And so then the natural flow of things, because especially if the electronic medical record and the computer system shared with this doctor this neurosurgeon or spine surgeon happens to be part of this system, that's just kind of where all the referrals go, and the patient doesn't necessarily have much of a voice in it. That's just how it is. We see more and more self-referred patients here. A large percentage of my patients now are self-referred. They're not referred by a specific physician or even nurse practitioner. See a lot of referrals from nurse practitioners now as they're carrying a lot of the weight of the primary care that's being done. But there was a time when there really wasn't a good way to research, who you're going to see. And, a doctor would send you to somebody just because that's who they've always used or that's who they're buddies with or whatever. And you just depended very much on that, physician to send you to, to somebody good. It's hard even for a primary care doctor always to know, who's particularly good at what they do and who's not as much so, because if they're not in their same field. So I always encourage patients to be their own advocate. And I think that, what that often looks like in our office is the opportunity, is our providing and even encouraging the asking of questions. So, it can be intimidating to, come and sit with a doctor in an office when, that doctor is supposed to kind of know everything about this problem. It's not your field. I've sat in my office with a diesel mechanic and I've said, look, maybe I can remember cases where they needed surgery, and it's my job then to explain to them what the goals of surgery are. Why are we even talking about going to the operating room? What the operation entails, what the risks are, and then in a general sense, what to expect after surgery, kind of a timeline. And I remind them that, if I had an over-the-road 18-wheeler and it wasn't running right and I brought it to you, I would be depending on you to do the same thing for me, right? Because you have expertise from training and years of experience about, fixing my vehicle that I don't have. Right? So every patient that comes in my office, I may have a lot of expertise in spine surgery or care of the spine, but typically there are multiple areas of expertise that they have that I don't know anything about. And so I normalize the fact that, there's a difference. I know all about this stuff. No, you don't. Now's an opportunity for us to spend a few extra minutes, right? We're not running through new patients here at NewSouth every 8 or 10 minutes, okay? You can't. That's not doable, right? If you got a wrist problem, you got an elbow problem, 8 or 10 minutes, plenty of time to do that. If you're being properly evaluated for a spine problem, that is not an every 8 or 10 minute patient run through the office kind of thing. And if that's what you're getting, you're probably not getting as thorough evaluation as you need. So I encourage patients to ask questions. Patients feel like I don't want to ask a stupid question. And so sometimes they won't. And, it's the same thing I'm at risk for doing when I go to a repair shop and ask a question about, well, why not that or why that? I ask a lot of questions. I still don't know a ton about it, but I ask questions so that I can better understand it. And I think that in addition to encouraging patients to ask questions, another part of being an advocate really for yourself is to find yourself sitting in the office of someone who's not trying to rush you out of the room as soon as they walk in. Somebody who is going to sit there and listen to you, and then not just listen to you, but then ask you questions. And I find myself oftentimes circling back around and maybe asking the same question a second time to make sure that I really understood you right. Like, is this pain, is it kind of, is this, is it going down the patient's like, yeah, it's going down my arm. And then I may ask, is it going down the inside of the arm or the outside of the arm? Because that teaches us a lot. It tells me a lot what nerve I should be suspicious of. Mm-hmm. Which fingers are numb and tingling? I'll circle back around and ask those questions again a second time. But you can't do that if you're not taking an adequate amount of time with the patient in the first place. And then if you're really going to examine someone properly, it doesn't take a ton of time, but it takes some time. And, it is required. If you're going to make good decisions, most of the worst outcomes I've seen in patients over 20 years of practice have not been because surgery went bad, right? The doctor got him in there, and instead of putting the screw in the pedicle, he stuck it right through the nerve root. Now, I've seen those cases, okay? I've seen cases that were really technically, like the doc got in there and he just did a terrible job with his hands. He didn't put the screw where it should have gone. He didn't adequately decompress the spinal cord or the nerve, okay? I've seen those cases where the problem is a technical problem. It's an intraoperative problem. The vast majority of the worst outcomes I've seen have been a product of people who never should have been in the operating room in the first place, winding up in the operating room and having something that they really didn't need, and having something that carries with it perhaps significant morbidity and an expectation that they're going to have some issues after you've had an operation of that magnitude. Mm-hmm. So that's really where, in my opinion, our most important work is done. It's in the office. As long as your surgeon is competent to carry out a procedure that they've recommended, people do not realize that. Everybody thinks, I want, the surgeon that is just the best of putting that screw there in the spine. And the reality is the vast majority of surgeons are pretty stinking good at putting stuff where it needs to go. Mm-hmm. The distinguishing factor is figuring out what's really wrong with somebody to the degree that it can be figured out. Sometimes it's just, you got a lot of arthritis in your back at multiple levels, and then there's no discussion of surgery at that point. But it's figuring out what's going on and then taking the time to think through it thoroughly and put together a plan. That is what matters, and that takes time. Mm-hmm. It just takes time. So I encourage patients to advocate for themselves and to ask questions and to expect to be given an adequate amount of time to be properly evaluated.
Well, good. You did a great job today. Thank you all who commented and who tuned in. We appreciate it. Remember, you can go to our website and request an appointment, request a second opinion. We'd love to see you and help you out if you need us. So thanks to John Davis, and we appreciate you guys tuning in. Have a good afternoon.
Thanks, everybody. Appreciate it.